Hi, I'm Jonathon Oskvarek. I'm an emergency physician at Suma Health in Akron, Ohio, and also a member of the MAT Task Force for U.S. Acute Care Solutions. I'm going to talk to you about the initiation and management of FDA-approved medications for substance use disorders. In particular, we're going to focus on treating opioid use disorder and also alcohol use disorder. We have three main objectives for today. First, I'd like for you to be able to determine the proper dosing of buprenorphine for opioid use disorder, and then also know how to prevent and treat precipitated withdrawal from opioids. Finally, I'd also like for you to know the various treatment options for alcohol use disorder. All right, so let's start with the case. Our first patient is a 27-year-old male. He does have a history of opioid use disorder. He snorts fentanyl daily, and he last used about 72 hours ago. Right now, he's starting to feel some mild withdrawal symptoms. His vital signs are as below. His temperature is 98.6, his pulse is 91, his blood pressure is 132/84, his respiratory rate is 18, and his oxygen saturation is 99% on room air. We calculate a COWS score for this patient. The COWS score helps us to quantify the severity and the type of the symptoms that this patient is having for withdrawal, and that will then guide our treatment for this patient. I'd like to draw your attention to a handful of symptoms that this patient is having and reporting to us. He appears flushed. That's something that we can visibly see. Perhaps his forehead is even a little bit sweaty. Also, he has rhinorrhea and tearing. And he also has a very slight observable tremor, in addition to him yawning a little bit during our assessment. These are objective signs of withdrawal, beyond just the subjective signs that this patient can report to us. So this patient has a total COWS score of 14. How can we help this patient out? Fortunately, there's a great medication that works so well for treating opioid use disorder. The medication is called buprenorphine. It is a long-acting synthetic opioid that is a mu receptor partial agonist. What that means is that it acts at the same receptor that other opioid medications such as heroin or fentanyl also work at. But unlike heroin and fentanyl, it is only a partial agonist instead of a full agonist. So it doesn't give a patient a euphoric high feeling. But by partially activating that mu receptor, it prevents full withdrawal. And because it's long acting, it prevents that withdrawal for a long time. So patients can be stably on this medication without going into withdrawal and without having cravings for those full opioid agonists that they misuse, such as heroin or fentanyl or other opioid medications. Buprenorphine is often combined with naloxone, and it's marketed as Suboxone. The naloxone, when the patient takes it as a sublingual tab, isn't actually active at all. The buprenorphine's partial opioid agonist effect outweighs that naloxone. But the naloxone is included with the buprenorphine to prevent misuse. If a patient tries to crush up the Suboxone tabs and inject them, the naloxone effect will outweigh the buprenorphine effect, and that patient will not experience a high. Buprenorphine is an FDA-approved medication for treating opioid use disorder. Buprenorphine works very well. Number one, it will efficiently alleviate the withdrawal symptoms that a patient is having. It also significantly lowers the already very high mortality from opioid use disorder. Patients who present to the ED after an opioid overdose, where I often see these patients, have a 5% chance of dying within the next year if they required naloxone for that opioid overdose. That's a very high rate of mortality. Fortunately, buprenorphine can reduce that risk by 62%. Very few medications that we use for any disorder work that well. Using buprenorphine or putting a patient on buprenorphine also doubles the likelihood of a patient remaining in treatment at 1 month, which sets them on a path for success in staying off illicit opioids. Buprenorphine is also an extremely practical medication. It works relatively quickly to relieve the withdrawal symptoms a patient is having. The onset is within 15 to 30 minutes, and the peak effect is after about an hour. There's no lab testing that's needed. It's not processed by the kidneys, so you don't need to get or check a creatinine prior to starting buprenorphine. It can also be given to patients who just got naloxone. And it has been shown to be cost-effective when started in the acute care setting. Also, starting patients on buprenorphine, often called buprenorphine induction, is a billable procedure, so providers can be compensated for their work with these patients. Buprenorphine should be given to opioid users who are in active withdrawal. What that means is that they should have a COWS score that's greater than 7, so 8 or higher. More specifically, and perhaps even more objectively, they should have 2 signs of visible withdrawal. As we talked about earlier with our patient in this case, there should be signs that this patient is flushed or is sweating. They could have a bit of a tremor, yawning, or other signs that make them look like they actually are withdrawing from opioids. And we'll talk about why that's important a little bit later. But the bottom line is that if we give patients buprenorphine before they're actively in withdrawal, the buprenorphine will actually put them into withdrawal. And that's an unpleasant experience. So we should avoid that at all costs. Also, patients should not be altered and should not be intoxicated with opioids or other substances before starting buprenorphine. To prevent precipitated withdrawal, we need to make sure that our patients have not recently used opioids. Methadone is a very long-lasting opioid medication, so it should not be given in combination with buprenorphine, and methadone should be not have taken within at least 72 hours, or perhaps even longer. Personally, I wait several days before starting buprenorphine. Also, fentanyl should not be have given to this patient within 12 hours. Okay, so now let's go back to the case. Our patient had a COWS score of 14, so that's mild to moderate withdrawal. We decide to give this patient a starting dose of 8 or to 16 milligrams of buprenorphine of the sublingual tab. Anywhere between 8 and 16 milligrams is a reasonable starting dose. Some algorithms recommend starting with 4 milligrams, but that is a little bit low, and too low of a dose might not alleviate this patient's symptoms. After we give buprenorphine, you want to wait 30 to 60 minutes before reassessing the patient. When we reassess the patient, as long as the patient is at least a little bit improved or stable, we can give another dose of buprenorphine, again between 8 and 16 milligrams. The patient might not feel 100% improved, but as long as they're feeling better, they can be discharged with several different things. Number 1, they need close follow-up, ideally within 72 hours with an addiction clinic. Number 2, you should prescribe them buprenorphine naloxone or Suboxone. The most common dose is the 8 milligram buprenorphine combined with the 2 milligram naloxone strips. They should take 2 strips every day, and you can prescribe them for about 7 days. That's a reasonable amount until they can make it to their follow-up appointment. Also, crucially, you should either prescribe or give them a take-home naloxone spray kit. Many emergency departments and other acute care settings, and even primary care clinics, have naloxone take-home kits available to give without a prescription. In fact, they're even in some vending machines now. This is a crucial medication to give patients because either they can use it in an overdose situation or they'll have it on them and they can use it with their friends or people who are around them also using opioid medications. And as a public health measure, it's been extremely effective in saving lives from the opioid overdose epidemic. All right, so that was our first case, and that patient did pretty well. Let's look at another case now. This time we have a 33-year-old female. She has a history of opioid use disorder, and she also snorts fentanyl like our last patient. She used last night, and she's presenting to us in the acute care setting this morning, now starting to feel some withdrawal symptoms. Her vital signs look pretty good. Her temperature is 98.6, pulse is 81, blood pressure is 128/80, respiratory rate of 18, and her oxygen saturation is 99% on room air. We calculate a COWS score. As a note of practicality, nurses and other support staff can also calculate the COWS score, but as providers, we should also be familiar with its elements and how to calculate it accurately. Notably here, this patient has a COWS score of just 7, which by the score is technically mild withdrawal. But as you can see, there aren't really any firm objective signs of withdrawal here. The patient doesn't look diaphoretic or flushed. They're not vomiting in front of us or appearing particularly queasy. They don't have a tremor, and they're not not yawning. So still a moderate score, a mild moderate score of withdrawal, but we're not really seeing much in person. Again, this patient has a COWS score of 7, which indicates mild withdrawal. We unfortunately decide to start with a pretty low dose of buprenorphine, only 4 milligrams. That's given, and then we check in on the patient 15-30 minutes later, and the patient is actually now feeling worse. We recalculate a COWS score, and it's now 18, which is obviously much worse than when we started with a COWS score of 7. We have placed this patient into precipitated withdrawal. Precipitated withdrawal, most simply, is just when we cause the patient to go into withdrawal by giving them buprenorphine. As we learned earlier, buprenorphine is a partial agonist at the mu opioid receptor, meaning that it does not fully activate that receptor. It doesn't give the full effect that other opioid drugs like morphine or fentanyl or heroin would give. But buprenorphine is way stronger of a binder to those opioid receptors than most other opioids. So it kicks off those opioid medications from those receptors and replaces it, but replaces it with a less strong activation of those receptors. So essentially, buprenorphine rips off the heroin, the fentanyl from those receptors, and then the patient feels a bad withdrawal syndrome. If you're to calculate it technically, it's an increase of a COWS score of at least 5, but you'll be able to see it. Patients will look and feel much worse when you put them into precipitated withdrawal. It's important that we don't do this because it is quite uncomfortable for patients. And if patients go into precipitated withdrawal, it can build mistrust between them and healthcare providers. So let's talk about how we can prevent precipitated withdrawal. First, before we give buprenorphine, we should actually make sure our patients are well into opioid withdrawal. That means, as before, a COWS score of greater than or equal to 8. But, and perhaps even more safely, we should be looking for at least 2 objective signs of withdrawal. Again, that's sweating or looking flushed, seeing a tremor, yawning, and other signs that make them visibly look sort of sick. The spacing between their last use of fentanyl and methadone is also very important. Fentanyl, we should wait at least 12 hours. And some people say that even 24 hours is safer. For methadone, this lasts a very, very long time in a patient's system. So sources say we should wait 72 hours. It's my personal practice to wait even longer than that for most patients. And if a patient is presenting and they're not in withdrawal, you could either send them home to come back to you to start this medication later when they are in withdrawal, or you can refer them to outpatient resources when they can be started when they are in withdrawal there, or you can prescribe a home start. This can be very effective for patients who are particularly savvy with buprenorphine or Suboxone because they've used it previously, or they have a fairly high understanding of healthcare and dosing, but there's more room for error. If you are sending a patient home without starting them or inducing them on buprenorphine or prescribing them Suboxone, there are other adjunctive medications you can prescribe. You don't have to send them home with anything. And this can be particularly important if you're treating these patients from a primary care or other setting. We're all capable of prescribing other medications, and there's a whole list that can treat their symptoms of withdrawal without directly prescribing them buprenorphine or starting them on that if you're uncomfortable. These medications include ondansetron for nausea, simple NSAIDs for the body aches they'll be feeling, loperamide for the diarrhea, and then you can also consider clonidine, gabapentin, baclofen, and trazodone as well, because they all really help with the very nasty symptoms of withdrawal. Eventually, if you treat enough patients who present with opioid use disorder, if you treat enough of them with buprenorphine, chances are that one of them might go into precipitated withdrawal. Fortunately, we have a lot of options for treating them, and actually the best option is to give more buprenorphine. So our patient here, let's say that they went into precipitated withdrawal. We can then give them a relatively higher dose of buprenorphine at 16 milligrams. In combination with a moderate dose of lorazepam, often just a milligram PO, patients may feel significantly better. So you can try these two medications, wait 15 to 30 minutes, and then reassess the patient. If their COWS score has decreased now less than 8, you can offer them an additional dose of buprenorphine between 8 and 16 milligrams in order to make them feel a little bit better. Or you can just send them home with a prescription if they would not like an additional dose. But if they're still not better, or if they're worse, you should give yet another dose of buprenorphine. So that would then be the third dose, the initial dose, the first rescue dose, and now our second rescue dose to treat precipitated withdrawal. You can also combine that with ketamine, which in several trials has been shown to be very effective and synergistic with buprenorphine. If they're improved after that, you can discharge the patient home with a prescription for buprenorphine and naloxone or Suboxone. But at this point, if they're not improved, we kind of need to treat them more aggressively. You can consider fentanyl, which is a full opioid agonist. And then you can also, again, consider ketamine. But at this point, they should probably be admitted. If you're in a primary care setting where more aggressive medications are not available and they're not improving with additional doses of buprenorphine, they should probably be sent to an acute care setting so they can receive a higher level of care. So to conclude our case, we give our patient an additional dose of buprenorphine at 16 milligrams, and we also give them a dose of lorazepam. After 30 minutes, this patient's COWS score is now 6. So the patient's feeling better. We offer her another dose of buprenorphine, but she is kind of done with the situation now and just wants to go home and get some rest. So we discharge her home with a prescription for buprenorphine, naloxone, or Suboxone. We also give her a naloxone tape comb kit, and we make sure that she's got a follow-up appointment in 3 days with an addiction clinic. We're going to shift now to discussing treatment of another substance use disorder that we see a lot, that I definitely see a lot in the emergency department, and is a very common reason for patients presenting to the acute care setting in general, and certainly presenting to almost any type of provider who sees patients. Again, we're going to start with a case. This is a 45-year-old female. She has a history of alcohol use disorder, and she drinks a fifth of vodka daily. She last drank this morning, and now it's about midday. She has no history of withdrawal seizures. She does report that she gets a little bit shaky when she stops drinking, but she can't ever remember having a seizure when she has stopped drinking. Her vital signs are pretty normal. She has a temperature of 98.6, a pulse of 78, blood pressure is 124/76, respiratory rate is 18, and oxygen saturation is 99% on room air. She's here for treatment of alcohol use disorder, so we calculate a CWA score. Her CWA score is 4. The CWA score is a step-by-step scoring tool that helps us to more accurately objectify the severity of alcohol withdrawal, and it then guides treatment. It includes several different symptoms that are associated with alcohol withdrawal, and they're graded on a scale. Obviously, very high means that the patient is having bad withdrawal. Very low minimal withdrawal. Our patient had a pretty low SUA score of 4, so we have different treatment options. The big categories, number 1, are: does this patient need detox? Do they need to go to inpatient detox? That would be a patient who's at high risk of having alcohol withdrawal seizures, or perhaps is medically complex otherwise. Patients can also follow up as an outpatient with a detox center. But some patients don't want either of these options, and they prefer to wean off alcohol on their own or to use other methods. So what can we do? Well, there are several medications that can be used to either treat withdrawals or to treat the cravings associated with withdrawal. We're going to start off with some of the medications that are used to actually treat the withdrawal syndrome. The most classic medications would be the benzodiazepines and barbiturates. The good thing about these medications is that they are very effective. They directly act on GABA, which is basically the main receptor involved in alcohol withdrawal symptoms. There are also long-acting versions of these medications, such as chlordiazepoxide and diazepam, which can last a long time in the patient's system, so they don't go into withdrawal or need to frequently dose, either with alcohol or with benzos. Unfortunately, there is a pretty high risk of misuse and diversion with benzodiazepines and barbiturates. Also, if the patient continues to drink, they may become oversedated and they can have harmful effects. Most providers tend to not prescribe benzodiazepines, and if they do, they limit their prescription to maybe only about 3 days to bridge this patient to other treatment options. And mainly that's due to the risk of misuse and abuse, and also the harms if a patient continues to drink. Carbamazepine is another option. It's very effective at treating withdrawal. It is a sodium channel modulator, and it is quite safe. Unfortunately, it can't be used in patients who have a history of seizure. And it may not be a medication that many providers are familiar with prescribing. Gabapentin, however, is a medication that many providers are familiar with prescribing. It is quite effective. It works as a calcium channel modulator, and it's typically used for anxiolysis, for sedation, but it also works quite well for alcohol withdrawal and cravings. However, there is a risk of misuse and abuse, and it has actually been found in a growing number of overdose deaths. So that is a pretty high concern for gabapentin. It also needs to be renally dosed. A final option is valproic acid. Not a medication that I very frequently prescribe, but it is available for treating alcohol withdrawal and has been studied in that. It's actually a mood stabilizer, but it has been shown to treat the withdrawal symptom. Unfortunately, it shouldn't be prescribed alone. It's most frequently used in combination with benzodiazepines. To treat cravings, there are a host of medications that have been studied, and also 3 that have been also approved by the FDA. The first, and perhaps the most promising, is naltrexone. Again, this is FDA approved, and it is very effective. It reduces alcohol cravings and reduces the number of heavy drinking days in patients who use this medication. It has a very amazing, very low number needed to treat of just 12. That puts it ahead of a lot of the other medications that we use for any other disorder. It comes in 2 different forms. One form is a 50 milligram PO version, so pill version, but it also comes in an extended release injectable format that's currently being studied. There are some caveats to this very promising drug, however. First is that patients cannot be taking opioids with this, either prescribed or illicit. If naltrexone is given to patients who have opioids in their system, they will go into withdrawal. So we cannot give this medication to any patient who has recently used or is on opioid medications, either illicit or prescribed. Also, It doesn't treat withdrawal symptoms. It can just be used to treat cravings, so we shouldn't really be giving this to patients who are in high risk of having seizures from alcohol withdrawal, or at least we shouldn't be giving it alone. And then finally, there is the issue of cost, especially with the injectable format. It is rather expensive and typically requires prior authorization. So certainly less practical in an acute care setting, perhaps something to still consider in a primary care or clinic setting. Acamprosate is another FDA-approved option for treating cravings. It works by fixing the imbalance between glutamate and GABA systems in patients who use alcohol frequently. It is very effective, just as naltrexone, but there are some issues with it. It is also quite expensive, and it does additionally require prior authorization typically. Disulfiram is the third FDA-approved medication for technically treating cravings for alcohol use disorder. Unfortunately, it doesn't really treat cravings. It's actually an aversion therapy. Disulfiram works by preventing the proper breakdown of ethanol, and so then it causes buildup of toxic substances that cause the disulfiram-like reaction, and it's quite uncomfortable. It causes a headache, flushing, palpitations. Patients feel pretty miserable, which you think might make them not want to drink, but they could also just stop taking disulfiram. So unfortunately, outside of an institutional setting, disulfiram hasn't been very effective, so it's no longer recommended as an outpatient medication. Gabapentin, in addition to treating alcohol withdrawal, does also treat cravings, but it has the same caveats that we mentioned before. There is certainly an abuse and misuse risk and diversion risk, and then it has to be renally dosed. A final medication that is somewhat commonly used for treating cravings for alcohol use disorder is topiramate. This is also involved in regulating the glutamate pathway, and it is quite effective. But there are a lot of bad side effects with this. There can be, namely paresthesias, and the dose needs to be really carefully titrated, so it shouldn't be prescribed unless there can be very close follow-up for titration of this medication. So let's go back to our case. So this patient has a CWA score of just 4, and she doesn't really appear to be in active withdrawal. So obviously, if this patient was in active withdrawal, we'd have to consider perhaps IV or PO benzodiazepines or barbiturates, but this patient doesn't require that. And this patient isn't interested in inpatient detox. So instead, we discuss with her, and she's interested in starting naltrexone. We prescribe her 50 milligrams PO daily, which is the common dose, and that will treat her alcohol cravings. We also provide her with follow-up information for addiction clinics. So let's review the takeaways from this lecture again. Now, I hope that you're able to determine the proper dosing of buprenorphine for opioid use disorder, because this is an extremely safe and effective medication for treating patients with this disorder. Also, I hope that you know how to prevent and treat precipitated withdrawal from opioids. And also, I hope you now know the treatment options available for alcohol use disorder. Thank you very much for your time and attention.